If you break your arm, getting an X-ray is, it's pretty satisfying in a weird way.
Oh, yeah, it's a very binary thing.
Right. Like you just look at the film
Yeah.
and the doctor points to this jagged white line and says, yep, there it is. Broken. It's incredibly clean.
I mean, we naturally gravitate toward that kind of medicine, things that can be easily visualized, neatly categorized, and then instantly fixed.
Exactly. But the moment you step into an intensive care unit and start looking at cardiovascular physiology, that comforting binary just completely vanishes.
It gets really murky, really fast.
Super murky. So today, we are taking a deep dive into a stack of physiology texts and nursing sources to unpack the actual physics of a failing human heart.
And it is fascinating stuff.
It really is. Specifically, for you listening, we're going to explore two monumental concepts you'll hear in any ICU, which are preload and afterload, and we're going to master a foundational rule of human survival called the Frank-Starling mechanism.
Which is just a brilliant piece of biology.
Definitely. But to start, I want you to do a quick mental reset. If you picture the heart as just like a squishy, passive bag that squeezes blood when the brain tells it to, I need you to throw that image away.
Yeah, that's not going to help us here.
Right. We need to look at it as a hyper-intelligent, self-regulating engine. Because by the end of this deep dive, you'll see exactly how the physical forces acting on this engine dictate why it runs, and more importantly, how it breaks.
And the reason this particular stack of sources is so compelling is that it sits right at the intersection of microscopic cellular biology, macro fluid dynamics, and really high-stakes bedside medicine.
We're literally talking about the physical forces keeping a human alive.
Exactly. Grasping these concepts, I mean, it isn't just an academic exercise for passing a physiology exam.
Right.
If you're standing at the bedside of a patient in cardiogenic shock, which is, this terrifying state where the heart pump is so weak it can't sustain blood flow to vital organs, understanding this, physics is the literal difference between saving their life and accidentally making them much, much worse.
Wow. Okay, so to understand how the heart fails, we first have to understand the invisible physical forces acting on it before and during a single heartbeat.
Right.
The sources focus really heavily on two terms, preload and afterload. So let's establish the technical definitions first.
That place to start.
So the text define preload as the stretch or the tension on the ventricular wall at the very end of diastole. So this is the exact millisecond just before the heart actually squeezes.
Yes, the true physiological definition there is end diastolic myocardial wall stress.
End diastolic myocardial wall stress, okay. And then we have the counterpart, which is afterload.
Right.
This is the resistance or the pressure that the ventricle has to overcome during the actual ejection phase, right?
Yeah, exactly. To push blood out to the body, the heart has to physically force open the semilunar valve.
Which is like a heavy door.
That's a great way to picture it. It's a heavy, pressurized door separating the heart from the aorta. So the true definition of afterload is peak systolic wall stress.
Okay, let's unpack this, because both of those technical definitions center on the concept of wall stress, which the sources note is governed by Laplace's law.
Right, and that geometric relationship, that is the core of everything we're discussing today.
So what exactly is Laplace's law?
Well, Laplace's law states that wall stress is equal to the pressure inside the chamber multiplied by the radius of the chamber.
Okay, pressure times radius.
And then all of that is divided by 2 times the thickness of the wall.
So it's pure structural engineering.
Exactly. It is structural engineering applied directly to living cardiac tissue.
Okay, let me try to ground this with an analogy just to make sure the physical mechanics are clear for you listening. If we think about a slingshot, is preload the act of pulling back the rubber band? Like getting that initial stretch and tension built up in the material.
Yes, perfectly said.
And then afterload would be like trying to shoot that exact same slingshot underwater versus through thin air.
Yeah.
Like the environmental resistance you have to fight against the moment you let go.
The math of Laplace's law actually supports that visualization entirely. Preload is the degree of stretch on the structural fibers right before the release, and afterload is the environmental resistance pushing back against those fibers during the release.
Okay, but I need to challenge the sources on something here because this always confused me.
Sure, go for it.
If true preload and afterload are both fundamentally about wall stress and the place's geometry, why is it that when you walk into a hospital, you constantly hear nurses and doctors talking about them in terms of simple volumes and pressures?
Ah, yeah, that is a classic point of confusion.
Right. Like you hear about CVP, central venous pressure, being used as a stand-in for preload, or SVR, systemic vascular resistance, for afterload. If it's all about stress on the actual heart wall, Why use these other metrics?
Well, that discrepancy comes down to a mix of historical evolution and just the harsh pragmatism of bedside medicine.
How so?
If we look back about a century, the term load, it wasn't a metaphor. Physiologists literally hung small metal weights on isolated strips of cardiac muscle in a laboratory to test tension.
Why, literally hanging weights on muscle.
Literally, it was a tangible physical load.
Yeah.
But by the mid-20th century, as cardiologists tried to translate that isolated muscle research into whole organ diagnostics for living patients, they needed something they could actually measure.
Right, because obviously you can't open a patient's chest in the ICU and hang a metal weight on their beating heart to measure the tension.
Exactly the problem.
Yeah.
So they started using ventricular volume and arterial pressure as stand-ins.
But the sources say that's flawed, really.
Very flawed. In the 1970s, physiologists like Kiichi Sagawa and Hiroyuki Shuga proved that using pressure and volume as proxies is fundamentally inaccurate.
Why?
They used pressure-volume loop analysis to argue that wall stress is the only mechanically honest definition precisely because of Laplace's law.
Okay, I think I see where this is going, but walk me through it.
Consider two different patients. Patient A has a severely dilated, paper-thin heart due to, say, a viral infection.
Okay, a thin, stretched-out heart.
And patient B has a thick, heavily muscled heart due to years of untreated high blood pressure.
Right, so if we plug them into Laplace's equation, where stress equals pressure times radius divided by wall thickness, the thin heart has a huge radius and a tiny thickness.
Exactly.
So its wall stress is going to be massive compared to the thick heart, even if the blood pressure reading inside them is completely identical.
That is the crucial insight, yes. A normal central venous pressure number on a monitor might reflect a totally safe amount of stretch for the thick heart, but spell absolute structural disaster for the thin, dilated heart.
Oh, wow. So the number on the screen is lying to you.
It can, yes.
Yeah.
The textbooks maintain the strict definitions of preload, but the clinical reality is that true wall stress is just incredibly difficult to calculate in real time at the bedside.
So clinicians use proxies like CVP and SVR because it's what they have.
Right. They just have to remain constantly aware that those proxies can be deceptive.
Okay, so if wall stress and physical stretch are so vital to how this engine runs,
Yeah.
how does the engine actually know what to do with that stretch?
Now we get to the magic.
Right, which brings us to the most famous concept in cardiovascular physiology, the Frank-Starling mechanism, or the law of the heart.
Yes.
The origin story in these sources is fascinating because it proves the heart manages all of this entirely on its own.
The discovery of that autonomy is arguably one of the most elegant moments in medical history. And it's hyphenated as Frank-Starling because the foundation was built in two distinct stages.
Right, on two different continents, nearly a generation apart.
Exactly.
The visual history here is so great. We start in 1895 in Munich with a physiologist named Otto Frank.
A true pioneer.
He isolates a frog heart and connects it to this device called a kymograph, which features a rotating drum wrapped in smoked paper to trace pressure changes.
Such a classic Victorian-era science setup.
I know, right? So Frank physically stretches the frog's ventricle before it contracts, and the smoked paper reveals a clear spike. Like, the more he stretched it, the more pressure it generated.
Which established the foundational length-tension relationship for cardiac muscle. But it wasn't until 1915 in London that Ernest Starling took that isolated finding and applied it to a fully functioning organ system.
And his setup was wild.
It really was. Starling developed an incredibly complex heart-lung preparation using an anesthetized dog. The heart and lungs were kept alive and pumping, but Starling's team artificially controlled the venous return.
Meaning the amount of blood flowing back into the right side of the
Right,
heart.
and they controlled it using an adjustable reservoir.
So they are artificially pouring more blood in, essentially forcing the intact heart to stretch. And what they find is revolutionary.
Absolutely revolutionary.
In his 1915 Lineker lecture, Starling revealed that when you increase that venous return, the heart automatically pumps out a matching increase in stroke volume.
The amount of blood ejected per beat, yes.
Right, so if 2 extra ounces flow in, the heart immediately stretches and forces 2 extra ounces out.
And the detail that reshaped medicine forever was that the heart did this without any change in heart rate and with zero input from the nervous system.
It's difficult to overstate how massive a paradigm shift that must have been. I mean, they essentially proved the heart isn't just a dumb pump waiting for instructions from the brain.
Exactly. It proved the heart has intrinsic mechanical autoregulation. It optimizes its own output beat to beat based solely on the physical volume of blood delivered to it. It is a fully independent machine.
I want to zoom in on the cellular mechanics of that independence, though, because earlier we used a slingshot analogy, but cardiac tissue isn't just rubber,
No, it's alive.
right? Rubber snaps back purely because of passive elasticity.
Yeah.
What is actively happening inside the microscopic muscle cells of the heart to make this autoregulation possible?
Well, to understand the active mechanism, we have to look really closely at the sarcomere, which is the basic contractile unit of a muscle cell.
Okay, zooming way in.
Picture it as a series of overlapping filaments called actin and myosin. For decades, the assumption was that the Frank-Starling law was just about optimal physical overlap.
Just spacing them out right.
Yeah, the theory was that if you stretch the sarcomere to a length of exactly 2.2 micrometers, the actin and myosin filaments align perfectly, allowing them to grab onto each other and generate maximum pulling force.
Which makes sense intuitively. It's like perfectly spacing out a row of people playing tug-of-war so their hands don't bump into each other.
It does make sense. But modern cellular biology has given us a massive update to Starling's original law. It's known as length-dependent activation.
Length-dependent activation.
Okay, we now know that stretching the sarcomere doesn't merely physically align the filaments better. The physical stretch actually triggers a chemical alteration in the system.
Wait, how does a physical stretch change the chemistry of the cell?
So think of the sarcomere like a dense, complex fishing net. Embedded in this net is a regulatory protein called troponin C, which acts kind of like a biochemical lock.
Okay, component C is the lock.
And calcium is the key that turns that lock to initiate a muscle contraction. When you physically stretch the sarcomere, you are pulling that net tighter.
Which distorts the net.
Exactly. That physical tension distorts the physical shape of the troponin C protein, fundamentally increasing its sensitivity to calcium.
That is incredible engineering. So by physically stretching the muscle, you are twisting the biological locks so they catch more calcium keys.
Which means more actin-myosin cross bridges form for the exact same chemical signal.
Wow, it's a hyper-efficient feedback loop where physical tension amplifies chemical reactivity.
Precisely.
Okay, so if the heart has this brilliant self-optimizing chemical net, how do we end up with patients dying in cardiogenic shock?
That is the dark side of the physics, unfortunately.
Right, because if Frank-Starling is a perfect regulatory mechanism, what happens when it gets trapped? Let's move from healthy theory into the physics of a failing heart.
This is where we see the physical laws just turn against the patient. Let's start with a normal, healthy ventricle. At rest, it fills up with roughly 120 milliliters of blood. That's your end diastolic volume.
Okay, 120 mils.
And when it squeezes, it efficiently ejects about 70 milliliters of that blood out to the body.
But when a heart begins to fail, say from a massive heart attack or chronic disease, it becomes weak and it starts to physically dilate. The chamber stretches out.
Yes, it balloons.
So that end diastolic volume might balloon from 120 up to 200 or even 300 milliliters.
And it does that as a desperate survival mechanism. The failing heart is trying to recruit the Frank-Starling mechanism. The muscle is weak, so it dilates to stretch those sarcomeres, hoping to increase calcium sensitivity and generate a stronger contraction.
But this is where the places lost springs a trap, right? Because as the heart dilates to get more preload stretch, the radius of the chamber gets wider and wider.
Yes. And returning to Laplace's equation, wall stress equals pressure times radius. As the radius expands, the wall stress basically multiplies. By trying to increase its preload, the failing heart inadvertently massively increases its own afterload.
Because it's suddenly fighting against its own huge geometry.
Exactly. It takes more and more energy just to open the semilunar valve. The heart enters this deadly downward spiral where it is working infinitely harder just to pump a fraction of the blood.
It's like shifting into a higher gear when you're already stalling going up a hill.
That's exactly what it feels like for the organ.
So, if the patient is trapped in that physical downward spiral, how do we fix the physics? The sources highlight an incredible piece of mechanical intervention called the intra-aortic balloon pump.
The IABP, yes.
And the way it manipulates these variables is just fascinating.
It's a masterclass in altering physical environments. It's literally a long polyurethane balloon inserted into the descending aorta.
And it operates on a strict timing cycle using helium gas, right?
Yes. It inflates while the heart is resting and filling, which actually pushes extra blood back into the coronary arteries to feed the heart muscle. But the magic happens in the exact millisecond before the heart squeezes.
Right, the balloon rapidly deflates.
Instantly.
And because it displaces so much volume, that sudden deflation creates a literal vacuum in the aorta. It instantly lowers the environmental resistance. the afterload.
The heart suddenly faces zero resistance, and blood is essentially sucked forward out of the ventricle.
It boosts the stroke volume immediately without requiring a single drop of chemical stimulant to whip the tired heart into working harder.
It physically proves that afterload is not a fixed static reality for a patient. It is a variable that we can manipulate.
Okay, but if the balloon pump is a physical machine that lowers afterload, what do we do when we don't have that machine?
That leads directly into the pharmacology sources.
Right, which focus heavily on two chemically related nitric oxide donor drugs,
Mhm.
nitroglycerin and nitroprusside. They're essentially chemical tools used to do the exact same physical engineering work.
They offer a really perfect contrast in how we manipulate the system. Let's look at nitroglycerin first. At standard doses, it is primarily a vasodilator. It specifically targets and relaxes the smooth muscle in the venous system.
The veins, okay, so because the veins expand, blood pools in the venous system rather than rushing back to the heart.
Yes, exactly.
So you've decreased the venous return, which means you've directly lowered the preload stretch and the resulting wall stress.
Which perfectly explains why a tiny nitroglycerin tablet under the tongue rapidly relieves the crushing chest pain of angina.
Because you are relieving the physical stress on the heart wall.
Precisely. Now compare that to nitroprusside.
Okay, how is that different?
It dilates the veins to reduce preload, just like nitroglycerin, but it also aggressively dilates the arterioles, which are the small branches of the arterial system.
So you were pooling blood in the veins to drop preload, while simultaneously widening the arteries to drop the resistance, effectively lowering the afterload too.
It lowers both sides of Laplace's equation simultaneously. That's why it is a frontline drug for hypertensive emergencies.
Where you need to rapidly unload a struggling ventricle that's fighting against massive arterial pressure.
Right. And the big takeaway here is that nearly every major drug class used for heart failure, diuretics, ACE inhibitors, ARBs, they exist fundamentally to manipulate the geometry of preload or the resistance of afterload. We use pharmacology to make the physical work of squeezing easier.
Okay, here is where it gets really interesting for me. With all these incredibly precise tools, timing balloons to the millisecond, isolating specific veins or arteries with drugs, you would assume the underlying mechanical models taught in medical schools are totally airtight.
You would certainly think so.
But the sources reveal a massive crack in the foundation. We need to talk about the descending limb controversy.
Oh, this is such a good topic.
Because it turns out one of the most famous diagrams in all of cardiology is largely a myth.
It's true. If you open almost any medical physiology textbook from the last 50 years, you will see the Frank-Starling curve drawn as an inverted U.
Right, a curve that goes up and then drops off.
The graph shows that as you increase preload stretch, stroke volume goes up, it reaches a peak, and then it plummets. This is the infamous descending limb.
So the accepted theory was that if you stretch the heart too far, the actin and myosin filaments pull completely past one another.
Yeah, that they lose their overlap, the cross bridges fail, and the heart suddenly loses all contractility.
So generations of doctors and nurses have been taught that heart failure is the result of this pure physical overstretch, like a broken rubber band.
Exactly. But an exhaustive historical review published in 2002 by Dr. Arnold Katz in the journal Circulation dismantled that idea completely.
How did they get it so wrong?
Well, that descending limb was demonstrated in isolated, denervated animal hearts, stripped of all their surrounding tissue and pushed to absolute extremes in a laboratory.
So not a real clinical scenario.
Not at all. In a living, breathing human chest, reproducing that physical overstretch is virtually impossible.
Wait, why is it impossible? What physically stops the filaments from pulling apart?
The human body has intense mechanical limiters built right into its architecture. Externally, you have the pericardium, which is the tough, fibrous sac surrounding the entire heart.
Right.
It acts like a rigid leather bag. Once the heart fills to the volume of that bag, it simply cannot physically expand any further.
It just hits a wall.
Yes. And internally, within the sarcomeres themselves, you have this massive structural protein called titin.
And the text described titin essentially acting like a molecular bungee cord, right?
Very stiff bungee cord, yeah. As the sarcomere stretches, titin tightens. Long before the actin and myosin filaments can pull completely apart, titin reaches its maximum physical length and abruptly halts any further expansion.
So these structures act as a physical straitjacket against the descending limb.
Exactly.
But we know that patients do get volume overloaded and their cardiac output absolutely does drop. If their hearts aren't physically overstretching because the pericardium and titin are stopping them, what is actually causing the curve to flatten out and the pump to fail in real life?
The failure is chemical and structural, not a pure geometric overstretch. In a real patient, the heart fails because of a loss of intrinsic contractility,
Meaning what exactly?
meaning muscle cells have died from previous heart attacks and been replaced by stiff scar tissue. Plus, the body attempts to compensate by releasing a massive storm of stress hormones, like adrenaline.
Which sounds helpful in the short term.
It is, but eventually those hormones become toxic to the remaining cardiac cells, causing them to fatigue and fail. So the graph flattens, yes, but the mechanism is entirely different than what the inverted U suggests.
So the textbooks got the shape of the graph right, but the physical reason for the shape entirely wrong.
Which is a huge problem.
Right, because holding on to bad models leads directly to dangerous decisions. The sources highlight how misunderstanding this physics leads to critical errors at the bedside. For example, using CVP, that proxy for preload, to blindly administer 2V fluids.
Yeah, for decades, the reflex in the ICU was simple. If the CVP pressure number on the monitor was low, the patient needed more fluid.
Just fill the tank.
Right. But a massive paradigm shift occurred, largely catalyzed by a landmark 1996 JAMA paper by Connors examining Swan-Ganz catheters.
What do they find?
The medical community realized that CVP correlates terribly with actual ventricular volume. The missing variable is compliance, or the physical stiffness of the heart muscle.
Right, because if a patient has a highly non-compliant stiff heart from years of hypertension, it takes very little fluid to rapidly spike the pressure inside that chamber.
And conversely, a very floppy, dilated heart can hold massive amounts of fluid without the pressure number rising significantly.
So if you blindly treat the pressure number on the monitor without considering the physical compliance of the tissue, you might drown a patient in IV fluid they don't need.
Or starve a patient of volume they desperately require.
Wow. Which brings up the absolute scariest misuse detailed in the texts, which is giving a pure alpha agonist vasopressor, specifically a drug like phenylephrine, to a patient who is actively in cardiogenic shock.
Oh, this is so important to understand.
I want to make sure the mechanics of this are crystal clear for you listening. On the surface, a patient in shock has a crashing, dangerously low blood pressure.
Yes.
And phenylephrine is a drug specifically designed to raise blood pressure. Why is giving it a potential death sentence?
Well, to understand the danger, you have to look past the blood pressure monitor and look at the receptor biology. Phenylephrine stimulates alpha receptors in the arterial walls.
Causing them to violently constrict.
Exactly. It raises blood pressure purely by massively increasing systemic vascular resistance.
And as we established when we were defining our terms, systemic vascular resistance is the primary driver of afterload.
Right. So imagine a heart in cardiopathic shock. It is already profoundly weak, struggling just to open the semilunar valve and push a tiny amount of blood forward.
Just barely hanging on.
Right. By administering phenylephrine, you are chemically clamping down on the aorta. You are basically building a concrete wall directly in front of a failing engine.
The tragedy is that the clinician might look at the monitor, see the arterial blood pressure number climb into a quote-unquote safe zone, and falsely believe the patient is improving.
When in reality, the systemic resistance is so high that the stroke volume drops to zero. The heart is beating against an insurmountable wall, forward flow completely ceases, and the vital organs just continue to suffocate.
Chasing a normal blood pressure number while ignoring the underlying physics of afterload will literally kill the patient.
It will.
So as we pull all these sources together, what are the overarching takeaways? We've seen that preload, the diastolic stretch and filling and afterload, the systolic resistance and ejection, they are totally distinct from a simple blood pressure reading.
Very distinct.
Along with contractility, which is the intrinsic strength of the muscle itself, these are the three independent dials that control stroke volume.
And we've explored the sheer brilliance of the Frank-Starling mechanism, how physical stretch alters the chemical locks of troponins to auto-regulate the system.
But we've also confronted the immense danger of relying on flawed proxies like CVP, or holding on to textbook myths like the descending limb when making life or death decisions.
You cannot just treat the numbers on a screen. You have to treat the physical reality of the engine.
Well said.
This deep dive actually prompts a fascinating question about where cardiovascular medicine goes next.
What do you mean?
Well, we established that the notorious descending limb of heart failure isn't caused by overstretch, right? Because of strict physical limiters. The pericardial sac and that giant molecular bungee cord, Titan.
Right, they stopped the stretch.
Right now, nearly all our therapies for volume-overloaded heart failure focus on manipulating the fluid. We give heavy diuretics to drain the tank and relieve the pressure.
Just getting rid of the water.
But if the pericardium and Titan dictate the physical limits of the heart's compliance, could the therapies of the future move away from just draining the fluid?
Wait, are you suggesting we somehow alter the limiters themselves?
Imagine if, instead of trying to manipulate the water inside the balloon, we designed pharmacology that chemically altered the elasticity of the pericardium, or instantly made the Titan protein more compliant when the heart begins to fail.
We could fundamentally rewrite the physical limits of the failing engine,
Exactly.
changing the molecular rubber of the balloon rather than just the water inside it. That is a brilliant concept to leave off on. So the next time you hear a monitor alarm or look at a textbook diagram, remember, you aren't just looking at a squishy bag, and you aren't just looking at a pressure number. You're looking at a dynamic, self-regulating engine governed by strict physical laws. Keep questioning the established models and keep looking for the physics beneath the surface. Thanks for joining us on this deep dive.